Hello, you're all very welcome to the third Scope patient event. We've had over 1,000 people register for this event, and I would like to take time to say a big welcome, and we are delighted to have you with us today. At Scope and these events, our ambition is to bridge the gap for you between the management, diagnosis and how to live day to day with dry eye disease. My name is Edel Duffy. I'm Head of Medical here at Scope, and it's my pleasure to be here with you today and also try and get a lot of your questions addressed with the experts that we have available to us today. So on that note, we're going to have a quick look at the agenda just so that you know what's coming up and so that way you know what section that you're most interested in or that you want to get your questions in for. So the first one we're going to look with Dr. Mile Brujic on imaging of the surface, the lids and the lashes. Then we're going to go in-store with Indy. Indy is our great optom that works for Scope, so we're going to go in-store with Indy. Then we're going to look at new and emerging technologies that, you may come across in the future or you may want to find out more information on for the future. And then also we're going to look at self-advocacy, new apps available, etc., that may help you manage the day-to-day discomfort of your dry eye and how to look for further advice. And then I'm delighted to say that we have a big Q&A session at the end. So I know with these events, we always get loads of questions from you. So please, please, please send in your questions. Just to say that there's two options for interacting with us today. There's the chat function. So the chat function is just general comments and things like that. Whereas for any questions that you have about your disease, your diagnosis, medications, treatments, you can put that into the Q&A box. So just to make sure, put any of those detailed questions that you want to get to me or to get to one of the team. I've got a big room behind me of optometrists, of experts. They're there. They're waiting to answer your questions, and they'll be sending me questions through on the iPad here, so then I can ask the experts. So this is your event. Enjoy it. Send in the questions. And we look forward to bringing you as much information as we can. And also, don't forget to blink. You're going to be looking at me, you're going to be looking at the screen for the next 2 hours. So every 20 minutes, take your blink, look away for 20 seconds, and keep your eyes happy and comfortable. So on that note, I'm going to go directly into our first session. So we're going to bring Dr. Mile Brujic from the US up on screen with me now.
Hello, Edel. How are you?
Hello. I'm so happy to hear your voice. It's great to have you. Welcome.
You as well. Thank you.
Great. Dr. Brujic, I'm just going to give a little intro to you because I have a lot to say about you, but I'm just going to top line it here. Dr. Mile Brujic is an optometrist doctor in the US. He's a partner of Premier Vision Group in Northwest Ohio. He practices full scope optometry with an emphasis on ocular surface management and specialty contact lenses. Dr. Brujic, I'm not going to mention all the publications you have. We're up in the hundreds and thousands. But I just want to say from working with you, you have a real patient focus and a real advocacy for the patient and wanting to progress disease diagnosis and management. So delighted to have you here. This afternoon here for me in the Ireland studio. I'm based in our head office in Dublin. And I know, Dr. Brujic, you're dialing in from the US. So good morning to you. You're starting your day.
Good morning and good afternoon to everybody.
Perfect. So, Dr. Brujic, we've had a lot of questions come in already to this event, prior to the event. And one thing was about specialist dry eye clinics. Now, you run a specialist dry eye clinic, and I know that you manage patients in a certain way, but you also diagnose patients in a certain way. Can you bring me through a little bit regarding when that patient comes through the door, regarding what you do in terms of diagnosis and maybe a little bit more focus on imaging, because it's not something that we all know what's going on when you're taking images in your practice. So just talk to me a little bit about that.
Yep. Well, Edel, I'll tell you, when you go back, so to give everybody a little bit more perspective on my background, I graduated in 2002. So I've been in clinical practice for 21 years. And the person, I still remember this individual who leveraged my passion towards this and helping people with dry eye, was a female who was 42 at the time. I used to refer to her as an older female. I'm 47 now, so I describe her as this young, hip 42-year-old female. But I prescribed her glasses, and she came back 1 month later, unable to see clearly out of her glasses. And through a further process, I saw very quickly that it wasn't anything to do with the prescription that I prescribed in her glasses, but it was the fact that I missed a dry eye diagnosis. And I did a few additional tests back in 2005, which is, again, an eon before where we are right now in terms of diagnostics. And I realized very, very quickly that two things were important here. One is I need to set up a system in place to understand this condition better and to make sure we're identifying it. But two, we have to make sure that when we're identifying it, we're tracking it appropriately and we're making sure the people that we're caring for understand it. And that's where my passion for imaging really kind of took over, because at that point, you now realize very, very quickly how abstract some of these concepts are until we can demonstrate it to patients. And it's a very visual condition, no pun intended, but when people can see what's happening with their eyes, people understand it, and now they can take more control of the condition. Because sometimes there are things where we can immediately change and influence the tear film, and other things require treatment that are going to take time. And the more a patient understands about what's happening on the ocular surface, the more they can partner with us in managing that and making it actually better.
Okay, do you know what? I'm just going to, there's a very, you mentioned a lot of things there, but just to make sure we're all clear, can you just describe, when you mention ocular surface and tear film, can you just describe what you're talking about regarding the tear film, or, you know, do you have imaging for that, etc.?
Yeah, and I do. And if somebody can enable my screen sharing abilities, I'll actually be able to show you that, Edel. But when we talk about the ocular surface, we're talking about all of the things that can control the way the tears are produced. That starts with the eyelids, the eyelashes, the small, what we refer to as the lid margin. So that is literally the space between the eyelids and where the eyelids actually touch the eyeball itself. And then the tear film that literally sits on the surface of the eye. Now, we don't normally think about the tear film. And the reason why I say we don't normally think about the tear film is because when it's functioning normally, we can see things very consistently and we can see things very, very clearly, and we don't feel the eyelid blinking. But when we look at the surface of the eye, we see all of these little things that can influence it. So when I say surface of the eye, what you're looking at here, Adele, is literally a high magnified view of somebody's eyelashes. Now, most of you on the call today may be looking at this and saying, well, I don't think I've ever seen my eyelashes this magnified. What you can also see here as well too is the small little waxy deposits at the base of the eyelashes here. And what I'm going to do here is I'm going to show you this next slide so you can see what these waxy deposits actually look like. And I'm highlighting them here with my cursor. These things can influence and affect the way that your eyes actually produce tears. And sometimes, even though somebody feels like they have a dry eye, it's not actually the eye itself that isn't producing tears correctly. It's these small little microbes or bacteria that are forming on the surface of the eye that are causing the downstream sequelae for what patients see. Now, Edel, this is another common imaging technology that we use. And what you're looking at here is in real time, somebody's tear film. Now, for those of you at home, what you're actually looking at is the surface of the eye. And what I've done is I've placed a little fluorescein dye. So if you've been to an optometrist or an ophthalmologist, you've probably had this dye at some point placed on your eyes. And this lets us look at a real view of your tear film in real time. Now, normally what happens is we're just supposed to see a green hue, like on the left-hand side, with no little dark spots forming. When dark spots form in the tear film, those are actually dry spots. And those dry spots make your tear film now not smooth anymore. It actually makes the tear film lumpy. And because it makes the tear film lumpy, when light hits it, it scatters, and you'll perceive that as blurry. So for example, if you have dry eye, and if you've ever felt like you need to close your eyes and just really kind of dig into them and wipe them, what you're actually trying to do without even knowing it is trying to sweep a fresh surface of tears on your eyes. And this is part of the reason why sometimes you might feel like, my vision seems better than other times, because usually as the day goes on, the dry eye symptoms and the ability for the tear film to cover the surface gets worse. There's other things that we can image too, Adele, like we can see corneal and conjunctival staining. The conjunctiva is the white part of the eye. The cornea is that clear structure that you look through. And what you can see here is on the white part of the eye, you can see all these dark little green dots. This is a special stain that we put on our eyes that we're trying to rehabilitate when we try and fix the eye. This is a little bit more concerning. Everybody can see these small little dots in the bottom left-hand picture here, where you're actually seeing, it almost looks like I took a green marker and put little dots on there. That's actually on the corneal surface that we're seeing that. So again, we're trying to rehabilitate these areas so that they're absent of this functionality. Now, there's other things that we can see. And again, Adele, you can see my imaging system right here behind us. This is actually what we use to image this. So when I'm seeing patients, I'm imaging this as I'm examining them. What you're all looking at here is an upper eyelid margin. You're seeing somebody's eyelashes here, but see this large waxy buildup right here? This is an abnormal finding. This is somebody who has something called meibomian gland dysfunction, where you actually have an oily cap that's overriding the surface of that little gland. We don't expect to see that. This is an abnormal situation. We don't want to see any capping on these glands. Now, what you're looking at here is me examining a patient, and I'm pressing along the lower lid margin, and I'm trying to push little oils out of the glands that are located along the lid margin right behind our eyelashes. And what you can see in this patient is I really can't push any oils out of this gland. This is an abnormal situation, and here's why. These tiny little glands that produce these oils, they actually produce the tear film that sits on the surface of the eye. So remember, I told you all that we have a little thin tear film on the surface of our eyes. Most of it's actually produced through this tiny little layer that's produced through these glands, or these tiny little holes in our eyelid margins. Now, here's where it gets very, very interesting, because what happens is we can look at the glands that are actually producing these oils. Take a look at this right here. This is an individual where I've pulled their lower lid down. And what you can see here in this individual is where the glands are, these small, tiny little yellow, what I refer to as nubs, and also where they're not. The problem, we expect these small little yellow nubs to actually extend all the way down the lid margin. And what we're seeing here is these glands that are specialized to produce these oils are shorter than we would expect them to be. And because they're shorter than we would expect them to be, they're starting to die off. So oftentimes we need to rehabilitate those glands. And by doing so, normally the first step is applying some level of heat, and then we have some more advanced procedures that we can do. At the slit lamp, at a closer view, you can actually see where the meibomian glands are and where they aren't. But we now have special imaging devices where we can measure this at a higher level of accuracy. This is called infrared technology, and this is a standard scale that we use to metricize the meibomian glands. And what you can see here is on the left-hand side, starting from a normal situation at the top, going to an abnormal situation. And you can see all these like little white strands here that exist. Those are all normal length meibomian glands. And you can see as you go down here on the left-hand side, you're starting to see less of those long white strands or meibomian glands. And what you also notice as well too, is they're becoming much more shortened. Again, that is a situation that we want to avoid. So this is a patient that I'm seeing in my office where I've averted or flipped the upper eyelid. So they're looking down, I've turned the eyelid up, and we're looking at them with infrared imaging. And what you can see in this patient is they have these long, healthy glands. And only in this real region right here do we see any level of dropout. But for the most part, this individual has a pretty good length of glands. This is how different it can look from the top lid to the bottom lid, because we have these glands in both eyelids. And you can see here on the bottom lid how short they are compared to the top lid and how long they are. So again, these are imaging technologies that we've included in our practices to really do two things, Adele. One, help us monitor the condition so we can determine success over failure over time. But two, we engage patients with this so that they understand really what's happening at a deeper level.
So interesting. I think we'll all be looking at our eyes slightly differently after that, Dr. Brujek. Just one thing at the start, we looked at the kind of the lashes and then the particles, I suppose, along the lashes. I suppose blepharitis is something that a lot of people have spoken about and asked questions about. Is it possible to see that with the naked eye? I mean, you know, what level can you start to see it yourself that you know you've got an issue? Because I know some of those pictures, there was a lot of mascara there in some of those images, yeah? So I'm presuming that mascara is going over the lashes, etc. So, you know, is there a way that you can see it, or what level can you see it at home without any special imaging techniques?
So we typically grade things on a scale from 0 to 4, where 0 is essentially normal. 4 is usually a pretty severe condition. Once it starts forming redness on the lid margin, and you'll see this, Adele, and for patients that are watching this, you'll look at yourself in the mirror and you'll say, my eyelid margin's right behind the lashes. It almost looks like somebody painted or drew a red line. That's where the inflammation is so severe that you'll actually see redness. In addition to that, with the deposits, or what kind of look like waxy deposits, usually at level 3 or level 4, presuming that you have good near vision, you'll be able to see that. But most individuals can actually see this with a magnifying mirror or magnifying mirror at home that they may use makeup. You'll sometimes see this at more modest phases. So at phase 1 and phase 2, you'll sometimes be able to see it with just a standard magnifying mirror as well too. And most of the time it's females that will have these. Males don't typically have these. So the females will be able to see that. But it's important to be cognizant of it, because you bring up a good point. Oftentimes we're putting makeup over it. And if you are, you're covering that up and you're actually promoting worse eyelash hygiene because of it.
Okay. I think that's a really good tip about the magnifying mirror for makeup. I mean, it's such a simple thing that you can do at home. But let's say one thing that we get questions on as well is, obviously you've got a specialist dry eye clinic, Dr. Brujek, but I think from the questions that have come in, not everyone has access or knows how to find somebody like you or a specialist dry eye clinic. So, you know, somebody's listening to us today, they suspect that they have dry eye, they're not happy with their management. How do they go and find somebody that's passionate about dry eye, but will have the imaging and will have the understanding of imaging to help with their diagnosis?
So, few things. First, one of the things that, although social media has its pros and its cons, one of the things that gives us an awesome opportunity to do is ask questions on a large scale basis and get feedback and opinions immediately. So just from that, most of our social networks are wider than we truly think they are. So if you share with somebody, these are the problems I'm having, and I'm really seeking somebody out to help me with these issues, you can't imagine how quickly people will respond to that, because there are others with your same challenges that have probably been in the same kind of seeking component to it. But the second thing is understanding the practitioner that you're actually then going to see. And one of the ways that we can do this, and again, patients almost apologize when they walk into my practice and they say, so I know you hate this, but I looked this up on Google. And I said, actually, it's the exact opposite. If you've started looking things up on Google, you are already more informed than 99% of patients that walk into my office. So I'm glad you did. What my job is now is to recalibrate everything and put things into context for you so that the things that you have learned about, we can talk about which one of those things applies to you and which one of those things don't necessarily do that. But the reason why I say that is because we can actually look up now histories on clinicians and practitioners. And for those that are actively publishing and writing and presenting on topics, you know those individuals are already passionate. But most importantly, looking at their website, if they're emphasizing dry eye care, then you know that's a practice that's likely going to provide those services for you. If you're going onto a website and they discuss the value of glasses and contact lenses, but nowhere do they talk about dry eye services, then it's probably not the right practice to actually go and seek for help in these instances.
I'm loving the practical tips here, because I said at the very start, day-to-day life, and that's exactly what we need. Things like mirrors, what to look out for on websites, etc. And you mentioned there about, you explain the images to your patients, which is a lot to hear, because obviously you're giving more information. But, how does that impact? Does it help with compliance, or how do you feel it helps patients when they actually get to see the images? Because I have to say, not all of those images that you showed look very nice.
Yeah.
So, what's your rationale for that, I suppose?
So Edel, depending on the size of the screen that people are looking at this at
Mm.
home, it can be more or less shocking. We actually have large screens in our office where we demonstrate everything. The first time a patient sees their eye up close, I say, now you've never seen your eye at this level of magnification. So things are going to look a little bit different than they do at just your standard eye. But I will tell you, Adele, what we refer to this as is our compliance officer, because what this does is it really gives us the ability to engage patients and just truly more or less help them understand. Because I found one of the biggest things in particular with new patients is they just don't understand their conditions. And part of it is because they can't picture it. There are patients who have dry eye who come in here complaining about their vision with no, what I consider traditional dry eye symptoms. Now imagine that. Somebody's coming into me saying, well, no, my eyes don't feel dry. I can't see as well as I want
Mm-hmm.
to. And now I have to go in and I have to educate them on why the dryness is causing the reduction in vision. So it's a path that's oftentimes not very logical for some people. Again, not because of anything with them, but just because they don't live, breathe, and die this on a daily basis. So we found that these images, they're almost forming a bridge between the clinician and what we know and the patient and what they know. And it helps narrow that bridge and that gap. And what happens is with follow-up visits, we find that the questions they ask become much more sophisticated, because as they go through this process, they become much more aware of the condition as well. So the imaging in particular is really that bridge that gaps what we know clinically and what the patient knows, and it makes that bridge much closer, to the point where now our established dry eye patients at times are asking me things where now I'm sometimes Googling things because I haven't heard of them, Edel. And that's what I want. I want my patients to push me as well too.
Well, I love your honesty. I absolutely love your honesty there. And I mean, every day is a learning day. And, one thing
Great.
you mentioned about dry eye and coming in, and I'm looking at some of the questions coming in, Dr. Brujek, and one of them is actually nearly the opposite. My eyes weep all year round, even using gel at night. My tear ducts are not clogged. I use eye drops every day, wear wraparound sunglasses. I'm at my wit's end and I play golf, weeping. What can I do? Because we've talked about dry, but just question when I see it come in is about weeping. It's watery eyes. So
Okay.
what's the
This is a very common misperception. I'm going to describe this so that everybody kind of can take this. And if there's one thing that I want you guys to remember is this last little tidbit. There's two types of general tears that the eyes produce. The first type, or type 1 tears, are the ones that just sit on the eye and literally just cover or coat the eyes. They're very oily and it's a very thin layer. They're what in normal individuals makes it so that when we blink, we can't physically feel our eyes. There's a second type of tear that our eye produces, and that second type of tear is a reflex tear. It's actually built, and I'm going to come up close to the screen, in a gland that's located underneath what we call the orbital bone. This second gland produces a tear that's more watery in nature. So it's, for example, if you've ever watched a sad movie and your eyes water, if somebody's emotionally done something to you where you're causing an emotional response to tear, that's the tear that comes out. If you've ever been hurt or hit and now you're in pain and you're crying, that's the type of tear that's activated. What's most of the time happening in individuals who have that weeping is that the primary tear, that type 1 tear, the one that was the oily layer that just sits on the eye, it's deficient. So what the eye does in response to that is it produces the second watery tear. And that's why oftentimes the primary complaint is, no. I don't have dry eyes. My eyes are too watery. When in actuality, they're not deficient in that second type of tear that I described. They're deficient in the primary type of tear.
Okay.
And if they're not producing that well, then they're going to get that reflex tearing. And Adele, I just want to show you one quick video to summarize this. So this is the eyelid margin. This produces that primary type of tear. Most people don't think about this, but you'll see in just a moment how much force I have to put to get, just see the little oils that are now coming out of the lid? That's not supposed to be that congealed or that thick. It's supposed to look like olive oil that's coming out of there, but what you can see is it almost looks thick like butter, like toothpaste. It's the absence or lack of appropriate type of oily tears that creates this trigger for the watering type of tears. I hope that that just helps clear that up a little bit, because that's the number one question we even get in our offices.
Okay. Well, it was obviously a big question coming in here. Dr. Brujic, I could talk to you all day, and I really appreciate the effort you've gone to with those images to make everything really real. But we're going to have to move on to our next session. So I wish you a very good day in Northwest Ohio. And I look forward to speaking to you again, and thank you so much.
Thank you. Nice to see you. Thank you, everybody.
Thank you. Bye. Bye-bye. So we've looked at in the office and getting a diagnosis. Now, oftentimes when you come out of that office, you're going to a drugstore, a pharmacy, an optometry office to look for, I need to go and purchase a lubricant or a product now for my dry eye. Now, this can be very overwhelming, coming out of that door and into a big shelf of products. So as I mentioned, my colleague Indy spent some time last week out in a pharmacy where she actually went in and had a look at the products available in store and what to watch out for. So we're going to have a little video with Indy now, and then Indy will join me in studio for some questions.
Hi, my name's Inderpreet. I'm an optometrist who works as part of the medical team for Scope. I'm here today at a pharmacy to take a look at some dry eye products. So let's go inside and see what we can find. Welcome to the eye care section here that I have behind me. I know it can be confusing with all the different types of drops. So let's dive in and see if we can make it any easier. Eye lubricants themselves are there to help you with those dry eye symptoms that you might be experiencing. There's a variety of different types of lubricants, drops, gels, sprays that you can get. So let's start off with eye drops. These will come in a variety of different bottle types and in sizes. Some of the bottles are going to look like this, where you squeeze them, and some of them will look like this, so you sort of push the top. Then we come across to gels, which are thicker than drops, so just be aware they are going to blur your vision temporarily when you're using them. Some gels will be thicker on your finger, but when they go into your eyes, they turn into a liquid like this one, so they're not sort of as sticky. If you are struggling with constantly sore eyes when you're using even eye drops and gels, then it might be a good idea to try a nighttime ointment before you go to bed. We say just before bed because these are going to blur your vision even more than gels or drops, so it'd be wise to use them directly before. However, if you are someone who really struggles with the concept of putting in something into their eyes, like some people do, there is an alternative, which is an eye spray. These work by spraying onto the closed eyelid, and they get into your tears that way. You won't get as much into your eye as you would do with a drop or a gel, so that's why it's recommended that you would try a drop or a gel first. All these different types of lubricants will have different consistencies, and the one that you're going to choose will depend on the symptoms that you're feeling. The worse your symptoms, the thicker that you want the lubricant to be to stay in your eye for longer and give you that longer lasting relief. But of course, you don't want constantly blurred vision, so it's finding that balance really for your eyes. So now that we've been through all the different types of lubrication that you can get, let's have a look at some of the ingredients. One of the ingredients that's really, really great for dry eyes is sodium hyaluronate, also known as hyaluronic acid. This is a really, really clever ingredient, and you might have come across it in some skincare products. It's something that holds 1,000 times its weight in water and is really highly moisturizing. That's what makes it so great for dry eyes. So it's really one of the ones to look out for when you're having a look at the side of the box for your products. One of the things to look out for to not have in your eye drops is preservatives. And one of the ones that is common and the bad one to look for is benzalkonium chloride, sometimes written as BAK. Preservatives are used to keep the drops bacteria-free for a longer period of time. But when you have dry eyes, think of it a bit like an open wound, and the preservative is going to irritate. So in dry eyes, just try and avoid all preservatives. These are some of the preservatives that are found in eye drops that you should try and avoid. So we've got cetramide here on the back of this packet, and then we've also got polyquat on the back of this packet. Some of the bottles will say preservative-free or on the side of the box, and that's great. That's one of the things that you're looking for. Of course, one of the factors that would play into what drops you're purchasing will be the price, especially with the rising cost of living. But if it looks cheaper on the face of the bottle, it doesn't always mean it's comparable. You need to look beyond the price, because if you're going to be using that drop less because it's thicker and it lasts longer, the bottle will last longer, so it's in turn more cost effective. So that was very much a whistle-stop tour on what to expect when you enter your pharmacy. Of course, any queries on products, your pharmacy is always on hand to help.
Perfect. Thank you, Indy. That was a great video.
It was great to be there at the pharmacy as well.
Absolutely. Not always an easy thing, because when you go in, it can be, as I said, quite overwhelming and quite maybe a little minefield. Now, Indy, I think you spoke really well there, but one word that I don't hear that often, or maybe not enough, is the word thickness and the difference in thickness between drops. Can you just go back a little bit there and just explain that one to me again, and for the patients, just that language that you use around thickness?
Yeah, of course. Of course, with all different types of dry eye products, the gels, the drops, the eye ointments, they can all vary in their different levels of thickness as well. But also drops, even within themselves, can have different levels of thickness. This is what we call in dry eye drops viscosity. So the higher the viscosity of the drops, the thicker that they are. And the higher the viscosity of the drop, the longer it will stay in your eye. So we get sort of that longer lasting relief, that longer, what we call retention time in the eyes as well. So we also want to match the viscosity of the tears to how sort of bad the dry eye is as well. So the worse that your dry eye symptoms, what you're feeling is, really that you want to have a higher viscosity drop as well, because you want it to remain longer into the eyes and give you that longer term lasting relief as well.
Is that something that, as a patient coming to you in your practice, that you will be advising on to watch out for and to look for kind of long lasting? Or,
Yes.
you know, how do you advise your patients to go and look for that?
Yes, definitely. Well, in clinic, it very much depends on what I'm seeing. I'm very, very lucky as in that position that I'm in, I have so much sort of equipment. So when I have a patient there, I can go through and ask them all the relevant questions, and then also put them on sort of the machinery to have a look exactly what's going on in their eyes as well. So then I can very much sort of lead them to the drop, which I think that will match in terms of the viscosity to the symptoms that they're describing to me and what I'm also seeing on them as well.
Perfect. Okay. Do you get many questions on that, Indy? Sorry, I'm going completely rogue here, but like, do you get many questions on that, or people are just happy, give me the recommendation and I'm happy to go with that?
So sometimes you will get patients that come back and say, look, this hasn't worked for me. And sometimes that happens. It is very much a trial process as well. And then we can basically see on how they felt with that particular drop. If they felt like it was too thick, if they felt like it was blurring their vision a little bit too much, we might need to drop it down, make it a little less thick, and just take it from there. So sometimes, yeah, patients do come back, and that's okay, because it's not, you know, a one piece fits all for patients. So we then tailor it again.
So if one drop doesn't suit, the message here is go back and look for the other one, because there's so much available.
100% come back.
Okay.
We want to fix it. We want to definitely help patients as much as we can, and we'd prefer you guys to come back and we tailor it for you again.
Perfect. Thanks, Indy. The next thing I want to move on to, and I think you mentioned it quite a bit there in the video, is preservative-free. So I suppose just give me the lowdown on preservatives would be great. And then, you know, if we preservative-free, you know, how do you do that? Like, and still make the product safe?
It's great, isn't it? Yeah. So preservatives are kept in the bottle to basically elongate sort of the shelf life of the product. You want to get rid of the bacteria that's in that product. And how that happens is, if you get a bottle, for example, and you use the bottle, you sometimes get airflow back into the bottle, sort of archaically, and that would, you know, introduce bacteria into that bottle as well. And the preservatives are basically there to kill the bacteria that's going to be entering that bottle as well. But preservatives, what they do is, when they go into the eye, it's quite a vulnerable sore surface, sort of in dry eyes. So the preservatives can sometimes irritate, sort of aggravate that dry eye in the patient's eyes as well. So we want to try and avoid preservatives at all costs. And, you know, not too long ago, that wasn't possible because we didn't really have preservative-free drops because of the bottles. But now we have bottles where you can have preservatives-free, because it's specifically a great sort of engineering feat with the products that you don't... it's the airflow of the bottle. So when you use the drop, you're not getting that reverse airflow. So you're not getting the bacteria back into that bottle. So it's a complete sealed
Okay. So what we're saying there is because of the movement and technology with bottles, we don't need to be adding something bad into the formula to compensate. So the bottle is going to do more of a job than just deliver the drop. It's actually stopping bacteria getting in, so therefore you don't need the preservatives.
Yes, exactly. Yeah, you don't need that added ingredient in there.
You don't need it there.
To make it,
Okay, perfect. Again, because preservatives are so damaging to the ocular surface.
Exactly.
Okay, that makes sense. So obviously we have 2 bottles here in front of us.
Yes.
There's a lot of information on pack, and I presume everybody can read that. But let's say if you want a bit more information on ingredients or how to use, etc., you're opening the bottle now for me, Indy. So you're giving me something else here. So what are you looking at here?
So when we open the bottle, I think one of the key things we do is we take the product out and we throw away everything else that has to do with it. I think we're all guilty of it, Adele. I'm sure everyone's probably guilty of it. But one thing that we need to be looking out for is this, great piece of paper. And this is what's known the IFU, or the Instructions to Use leaflet. And this basically tells you everything for the product that you need to know. Sorry, it's crinkling a little bit as well. Get it out. So it's basically your best friend completely before you use a product. I'll hold it up there that you can see it. So it has the ingredients. So some of the key ingredients to a drop might be on the outside of the box, but some of them will be inside when you read the instructions leaflet as well. It goes through what it should be used for, so what that specific drop is indicated for as well, when it should be used, and how to also use it as well. A lot of the time, if you get a new drop, a new bottle, you don't know how to use it, it will show you exactly how to prime the bottle, how to use it, so you can get the most out of the product. So rather than sort of fiddling about with it, it just gives you, 3 steps on this one, so you can know how to use it as well. On this one, if you turn it over, it goes through what else you should need to know. So some things that maybe you can't use the bottle with. So say, for example, if you're nursing or if you're sort of pregnant, you might not be able to use specific products. So it will give you all that information on top of this IFU as well. And how often and how long you should be using the product for as well. It's got great things such as like storage as well. So where you should store the bottle, which is great to know. Do you keep it in the fridge? Do you keep it outside? And of course, if there's anything that isn't answered within this leaflet, then, there's some contact information always at the back of it as well. But your first port of call should always be your IFU, your information for instructions leaflet. And then if it doesn't answer your questions, then go back and contact us.
Perfect, Indy. I am totally guilty of not reading the instructions of many things, which is a big frustration for my husband, but absolutely. So basically, read the instructions.
Always read the instructions.
Perfect. Thanks, Indy. Actually, a wealth of information on that. And I think oftentimes with eye drops, compared to maybe other things, it's very, very practical information.
Yes.
Like you said. Perfect. So during the call, actually the very start of that call, you talked about products in general, and then you focus on eye drops. Okay. But you mentioned heating and cleansing and things like that. Where does all that fit regarding eye drops, heating, cleansing, and what it's all about? So just give us a lowdown on that.
I think Dr. Bridget covered on it a little bit on the sort of the last session as well. So the majority of dry eye is sort of due to poor quality tears. So a top component of the tear film, as sort of Dr. Bridget just explained really well, was the oily layer of the tears, which helps to sort of prevent the evaporation of the tears from the surface of the eye as well. The oily layer is sort of produced by the bottom of the eyelids and the glands at the top of the eyelids as well. So we want to try and help protect those, and how to help sort of clear them a little bit more and produce those oily layers a little bit more. We need to heat the eyelids. So we need to go through sort of warming mask heating procedures, and then also sort of very gently massaging those glands as well. So rolling up is what we say, and rolling down just to release sort of the oil from that layer as well. And then also just cleansing away that bacteria that might be built up on the eyelids as well.
Perfect. So basically, when he was showing, let's say, the more the solidified or the hard oil,
exactly,
the heat is to get rid of
when
that.
it was really like butter, like he was describing, we want it to be like little olive oil.
So
puddles.
Heat will do that, and then what we saw with the mascara and the blepharitis, the cleansing, will get rid of that.
We want to get rid of all that sort of bacteria.
So root cause as well as the comfort of the drops.
Exactly. Yeah, we want to get right to the root cause.
Indy, thank you so much. We'll have you back another time, I think, to talk, because I think there's a lot more to explore. But thank you very much.
Thank you for having me.
Brilliant. So Indy's obviously been in the store and looked. So we've done the office, we've been to the drugstore, but let's say when you get home, What are the little things that you can do within your home regarding ergonomics? And even we all work from home so much nowadays. We have a little video coming up now just to go through how you can set up your workstation and little tips and tricks for in the home of how you may be able to alleviate symptoms and maybe stop worsening of symptoms.
Many people who spend long hours reading or working on a computer for their jobs experience eye discomfort. Focusing on tiny type for hours on end can cause eye strain, fatigue, and headaches. Staring at screens for long periods can also leave eyes parched, red, and gritty feeling. To help avoid workplace dry eye and eye strain, follow these eye ergonomics tips from the American Academy of Ophthalmology. Arm's length away. Eyes have to work harder to see up close than far away. If you have a desktop computer, try placing the monitor 25 inches away from your face. Put your screen an arm's length away. You may need to adjust the type to appear larger at that distance. Many new phones and laptops have glass screens with excellent picture quality. They also produce a strong glare that can aggravate the eyes. If you use a glass screen device, try a matte filter for your screen. Just as carpal tunnel syndrome from overuse can hurt your wrists, eye strain occurs after long, continuous periods of reading paper or viewing digital screens up close. Follow the 20-20-20 rule. Take a break every 20 minutes by looking at an object 20 feet away for 20 seconds. Looking into the distance allows your eyes to relax. Many newer office buildings have humidity-controlled environments that suck moisture out of the air. In winter, heaters on high can further dry your eyes. Try a desktop humidifier to add localized moisture. Keep artificial tears at hand to help lubricate your eyes. When your screen is much brighter than your surroundings, your eyes have to work harder to see. Adjusting your environmental lighting can reduce eye strain. Also, try increasing the contrast on your monitor.
Welcome back. I hope you found some of those tips useful. We're moving on to our next section now. So I'm honoured to be joined by a panel of 3 people to help with this session. So here beside me is our resident optometrist, Mandy Davidson. Mandy is a practicing dry eye optometrist with a specialist clinic just outside London. And Mandy, you're a wealth of knowledge regarding the practicalities of dry eye. She's laughing, but it's the truth. Also on the line, I'm being joined by Dr. Laura Perryman from Seattle. So hello, Laura. Coming in. Hello, Laura.
Hello. Hi, Laura.
You're very welcome, Laura, and we have a terrible habit of making Laura get up very, very early for these kind of events, and she always looks amazing. So thanks, Laura, for joining us. Laura is a board-certified ophthalmologist, a fellow-trained cornea and refractive surgeon, and ocular surface disease expert. Laura, you have so many peer reviews and your writing is amazing on this topic. You are an innovator, and you love, and I've heard you so often, and you love bridging the gap between real science and practicalities for patients. And Laura, that's why we bring you back year after year. So thank you for joining us again. And again, so much has happened in the past year that there's no way we could not invite you back to share everything that's happened in the last year. So thank you for joining, Laura.
My pleasure.
Great stuff. And also we have Mr. Conan Tan. So Conan, you're going to come in now. Conan, lovely to see you. You've had a very, very busy week. We are so happy that you're here. I have to congratulate Conan on a brand new baby in his house this week. So we really appreciate you being here. Mr. Tam is duly qualified in orthoptics and optometry and is an independent prescriber in the UK. He's worked in Great Ormond Street Hospital, Hildington Hospital and St Thomas's Hospital in London, and he also is a director at an independent practice, Burnett Hod and Tam Optometry, and you set up the Dry Eye Centre. Conan, when I look at your bio, what really strikes me is that you have an interest in this because of personal experience. After receiving eye surgery as a child, you went on to develop severe dry eye, and you have taken the road to try and make this better for everybody else because you understand it so well. And also, I really admire the fact that you have the power to go and do something about it. So we are delighted to have you here today to speak with us.
Thank you.
Brilliant. So we have a nice session today. I'm hoping that, just to remind everyone, please enter your questions. I'll get your questions, and I have these people in front of me. I don't want them getting away without having lots of hard questions to answer, so please send them in. But just to start with, we've talked about in the session getting a diagnosis and using imaging. We've talked about getting the lubricants. We've talked about what we can do in the home. There does come a stage where that's not enough. Okay, so that's what we want to look at, different treatments, and then we'll go on to medications. So IPL, those three little letters are quite frequently spoken about, and maybe more so by patients even compared to last year. So both Conan and Laura, I'm going to come to you on that, but just Conan, what is IPL? Give us a definition, tell us a little bit about what it's about, so we're all starting from the same base, because we have people joining us from Ireland, from the US, from the UK today. And, you know, not every therapy is available everywhere, but IPL is one thing that is available in all countries. So just tell us a little bit about that.
Sure, yeah. So IPL, or intense pulse light, is light delivered with specific wavelengths and energy to reduce inflammation and to improve meibomian gland dysfunction. As we heard before, there are many changes that happen in dry eye. To the lids. Inflammation causes these small blood vessels to develop, as Dr. Brugic mentioned before. These blood vessels are called telangiectasias. They increase the inflammatory markers that are delivered to the lid margins, and in turn, the inflammation transmits to the meibomian glands, causing them to dysfunction. So as he mentioned again, rather than producing nice olive oil type consistency, you get pasty, solid kind of substance coming out rather than nice oil flow. So IPL has several mechanisms of action. When the light is targeted to the skin, the energy is absorbed by the hemoglobin of the blood vessels, the abnormal blood vessels, which causes photocoagulation. Now, this closes these abnormal blood vessels and so restricts the delivery of these inflammatory markers. Another key mechanism is photobiomodulation. So this is where the action works at a cellular level. It increases the energy production of the mitochondria within the meibomian gland cells, and that promotes the healing and improvement of function of these glands. Excuse me. IPL also reduces the bacteria and microorganism load along the lid margins. And finally, the heat that's produced by the IPL treatment can help to liquefy and to promote a better flow of the meibum. All these actions help to break that inflammatory cycle that we see in dry eye.
Perfect. So really, you know, it wasn't a simple one-line answer there, Conan, was it? Because it's got so many ways of working, which is probably maybe why it's so effective. But Laura, I'm going to come to you now. So this is a great treatment. You know, who do you consider for this kind of treatment? So, you know, what triggers you to start a patient on IPL?
Right. So IPL is very interesting because it has a long list of approved indications, dermatologic conditions, rosacea, acne, and oftentimes our dry eye disease patients also have those dermatologic conditions. So if a patient presents with other dermatologic conditions, I'm fast to offer IPL therapy as a drug-free way of improving the neighborhood, right? The eyes are not in isolation. It's a local regional problem, dry eye disease. So I'm very keen to identify and address any dermatologic component to that dry eye disease, meibomian gland dysfunction patient. IPL also has FDA approval in the United States and at least 3 other countries specifically to treat dry eye associated with MGD. And specifically, the OPT technology is regulatorily approved for these indications. It's the only one. So we reach for IPL in dry eye associated with meibomian gland dysfunction, dry eye associated with dermatologic conditions. And really how I coach my colleagues is look at the whole person, look at the face, and identify what's in front of you and treat what's in front of you. And that more integrated approach, that step back, integrated approach, I think is one of the keys to our patients' successes.
Okay, and Laura, on that, you know, because I just see a question coming in here. So it's from, you know, somebody's writing in on behalf of their mum who's quite elderly, has arthritis, bruising, very delicate skin. Because you just mentioned dermatology there. Is it too strong for those kind of patients, or is there somebody that you would say, no, not going to go ahead with IPL for this type of patient?
I love that question. And in that situation of elderly persons with hand mobility issues, IPL is a brilliant way, excuse the pun, for addressing inflammation and dry disease associated with MGD in a drug-free way. What we find is that IPL, pardon me, with OPT technology helps to reduce the drop burden. And if you have compromised hand function, this can be very helpful for the patients. You did ask, who would we not use it for?
Yes.
And it turns out that if you have a very rich skin tone, we call this Fitzpatrick skin typing. If you have very rich melanocyte tone, like a skin type 6, it is not recommended. IPL is not recommended. We can do some early skin type 5s with great experience and great caution. That can be done, but it really takes an experienced operator who's been doing it a long time to know where those safety margins are. In addition, with respect to the bruising question, IPL can actually help address the bruising. It can help break up those broken, the blood that has seeped into the tissues, and help the bruises resolve much quicker. Way back 30 years ago, when IPL first became available, the energy we delivered to the skin was so strong that it often created bruising. Modern technology, modern algorithms, far, far less risk of that.
I think, Laura, what you've done with that is actually given them more reason actually to go and look at this option for that patient as opposed to be afraid of it. Thanks, Laura. So you mentioned there about precautions and stuff like that, and you know we've looked at that, but I still, there's so much out there, and I'm not in a clinic every day. So Conan, I know you've got some pictures that you're hoping to bring us through what this actually looks like. So I'm walking in, and Laura, I'd love to visit Seattle someday. I walk into your lovely new clinic, or Conan and I walk into your clinic. You know, what kind of machine am I going to see? And you should be seeing some pictures coming up now, Conan and Laura, regarding some what you can describe there, just so that it's not, I suppose, to make it accessible and it's not a scary thing, I suppose, going into enough to get this done.
So I believe we both use a similar technology, OPT technology. So going through the visit, a patient coming in, we always perform a quick slit lamp examination in between IPL visits. We ask the patient to remove any makeup, any sunblock, any moisturizers. We get them comfortably in the treatment chair. And the first thing we do is we apply the eye protection. So we use primarily stick-on IPL shields, but we do also have the option of using the scleral shields, the stainless steel scleral shields, which Dr. Perriman, I believe you use as standard.
Yes.
Yeah, and what we do is we apply the IPL gel first. Now, not all IPL devices will follow the same protocols, but with these machines, we use gel to help to conduct that light treatment. So we apply the gel into the treatment areas, and we do 2 passes from ear to ear over the nose, all the way across. Like I said, 2 passes. Once we've done that, we have the option of doing the upper lids as well, as you can see in that image. We reposition the IPL shields if we're using these stick-on ones, apply more gel, and we can use the pen that you can see in the picture there to apply that OPT IPL directly to the top lids. Again, I personally do the 2 passes, and as soon as that's done, I take them away and I get them back onto the slit lamp and do some squeezing.
Okay. Laura, do you do it similarly, or do you have any different protocols for that?
We do have a quite different protocol. And here's the lovely thing about IPL with OPT technology. There seems to be a very wide range of techniques that work, and also energy applications that work. So it's not always about more power. That's such an American thing. More is better. No, not always. So you have to nuance this, right? So it has a lot of, I call it forgiveness within the system, especially modern OPT technology, IPL platforms. It's very important. So we do pardon me, an aggressive 4-step protocol. I have my videos on YouTube. You're welcome to see them. I use less gel these days, though, when you go back and look at those photos. But we do take the time to sterilize metal laser grade corneal shields to protect those beautiful eyes, put them underneath the lids, and that allows us to apply IPL energy for the whole face, treating the underlying dermatologic condition, such as rosacea, seborrheic dermatitis, acne. And then we'll do the cheek-to-cheek pass, the photobiomodulation passes. Then we'll switch to the small light guide with eye protection in place. Allows us to apply that wonderful IPL with OPT technology energy to the lids, avoiding the lashes by about 2 to 3 millimeters. We don't want to lose those lashes. And then step 4 of the Perryman IPL protocol is what I call aesthetic cleanup. And that could be going back after a chalazion. We were the first to describe using IPL to address active chalazion, chronic chalazion. We did an IRB-approved study with excellent results. It could be treating telangiectasias around the nose, which are common features of rosacea patients. And sometimes we will treat unwanted hair on the chin. Of course, no extra charge, and it's just a lovely thing that many of our patients really appreciate.
Thank you. And I think that's really important that we have the different perspectives here, because as I said, we have patients from all around the world. So I suppose, you can go into a different dry eye clinic and they may have a certain different protocol that they use, and that's still going to work in terms of the IPL treatment, etc. So thanks so much for sharing, that there are differences there. There will always be differences. There's difference in dry eye treatments, lubricants, there's difference in everything we do. But, and that's important to understand from a patient, because I think Google can sometimes mix people up a lot, and then they're questioning different things because they're getting different information from different sources. So just on that, Laura and Conan, is there anything that a patient needs to take into consideration for them before they start treatment? Is there any impact of doing the treatment on their daily life? I think someone mentioned just cleaning everything, but is there anything else that they just need to be mindful that they'll have to adhere to for this treatment? Conan, I don't know if you want to take that one first. Or
Yeah,
Laura,
sure. I've said this before, but in this country, we don't have to worry so much about it. But if a patient is in a hot climate or is going to be subjected to high levels of UV, you've got to be careful about protecting the skin around the IPL treatments. So, if someone's tanned, we may have to turn them away. However, some of the IPL technologies do allow us to adjust the settings to still deliver IPL in a safe fashion. And applying sunblock after treatment and avoiding sunlight afterwards is very important. Okay,
perfect. Just because we, again, under a bit of time pressure, Mandy is here beside me, and I've got a 4-letter word for you, LLLT. So tell me the difference with LLLT and how you use it for your patients, just so that we get perspective on all of that.
Okay, so LLLT is low-level light therapy or photobiomodulation, which Conan touched on at the beginning. And this works in a slightly different way to the IPL. You sit behind a mask, and it's near infrared, so it's energy of a certain light, a wavelength, that targets the powerhouse of the cells within our body, those mitochondria that are responsible for all the energy factories, if you like. And that actually generates heat from within rather than applying external heat. So I think we've got a photograph of a mask, and it looks a little bit space agey. I think you'll see it on screen now. This is one of the photos that Conan kindly sent in. So you sit with this mask on under the red light for 15 minutes and you relax and let it do its magic. So it reduces inflammation, it increases blood flow, it liquefies the meibum, and actually, do you know what? Immediately you start to feel an effect or the benefits of it once you take the mask off. I'm going to be a bit cruel now because I've actually got another photograph, and I've got the photograph of you when you came to my clinic and tried it, and I thought it might be interesting if you could just tell us what it's like to experience this.
Oh, I love when I'm put on the spot. Thank you, Mandy. Yeah. No, actually, you know, I get facials done sometimes, not enough, I don't think, but it's a very pleasant, actually, experience, very relaxing one, very holistic. I mean, it just felt relaxing time, to be very honest with you. So it was absolutely comfortable, fine, and an overall nice experience.
And that's really good to hear because it is pleasant, and I think it looks more scary than it actually is.
Yes.
But immediately after I've done that, everything's nice and warm, and like Conan and Laura, after that, I would go in and I would pop the patient back on the stick lamp and have a squeeze. You can get rid of all that that liquefied oil that is the bad quality to allow the fresh oils to come through. And actually, patients do say afterwards, it feels amazing. It feels like a sort of a warm veil of comfort coming over their eyes because suddenly you've just released all this oil. So yeah, I actually use it. I've got a slightly different IPL system, and I use it in conjunction with my system. So they have their IPL, and then they sit down and relax for 5 minutes as their reward, while it all does sort of a double whammy for them.
Perfect, thank you, Mandy. And I know we've chatted before about how some patients that have not got relief ever have come in and done that treatment, and they've been, you know, really, really impressed. Yeah. I have some questions coming in now, just for both Conan and Laura. Laura, this is a very specific question. Can you have IPL if on warfarin? So just about the patients that you watch out for?
Absolutely.
You can.
There's some photosensitizing medications that you should avoid in the proximity of IPL treatment. The most common one is doxycycline, which has never been my favorite strategy for treating rosacea.
Okay, so watch out for that one. Okay, and Conan, just how often do you have to have IPL? Is there a set protocol, time period regarding what's the most effective number and length of time to have IPL?
Yeah, so we suggest doing a 4-course treatment. However, that number can vary depending on the severity, but most people is a 4-course strategy.
Of course.
And the sessions should be a minimum of about 2 weeks apart. But again, that depends on the type of IPL device that you're having the treatment from. Some are a little bit more aggressive, which require a little bit more time in between the treatments for the skin to settle.
Okay. I'm just going to quickly move on. Again, I think there's a real interest here in IPL, but we have 30 minutes Q&A session at the end of all our talks, so we'll come back then and do a little bit more on that one. I just want to briefly cover medications. Laura, I'm going to put this one to you. Just regarding, okay, you've got the treatments. When do you start medications? What type of medications? Just give me a few lines on your patients regarding medications.
Sure. So we do some diagnostic testing in the clinic. I need to know how well the lacrimal gland is functioning. I need to know what the inflammatory burden is in the tear film. So we do objective testing with osmolarity and MMP9, which is a marker of inflammation. If that marker of inflammation is strongly positive, that will push me to be more aggressive and proactive in getting that inflammatory load under control. Of course, we're leading with IPL, radiofrequency as indicated for any lid malpositions, laxity. Then I'll reach for a combination of steroids, immunomodulators, whatever I can get through the insurance company. That's a big problem in the States. And then, of course, you've got to use your moisturizing drops. That is an important foundational strategy that still continues through all of these fancy treatments.
Okay, thanks, Laura. So I'm hearing steroids and things like that, start them. I think we have a lot more questions to address the next section on that regarding how long, etc., for steroids. But just to get the UK input on that, Conan, because you are a growing but early person in terms of being an IP or prescriber of medications as an optometrist in the UK. What kind of approach do you take? It's quite different regarding, let's say, funding, etc., in the NHS in the UK versus the US. So what do you reach for?
Yes. So again, when there are significant signs of inflammation, we will consider doing a steroidal drop to begin with, to dampen down the inflammation. And this could be done before IPL treatment, which often makes it a little bit more effective. But also we see a lot of coexisting allergy as well. So we may reach for short courses of antihistamines, or if someone needs a slightly longer course, it would be mast cell stabilizers. And as Laura mentioned before, you know, we for the more severe and the more persistent ones, we can reach for cyclosporin, things like that. Now, the funding for these drops can be a bit tricky, especially the cyclosporins, which are more expensive. So it really just depends on whether the general practitioner will be willing to prescribe that. If not, then there is the option of purchasing it privately.
Okay. Okay, I think there's a huge amount there, and we're getting a lot of very specific patient questions in on that. So what we're going to do is we're going to look at them, and Laura and Conan, Laura, I know it's early for you, you've got clinic today, so, and I know, Conan, you can stay for a little while, but I might go and we'll look at some of those questions and come back to you, the patient, after the next section. So the next section, we're going to have a little video first, just regarding diet. And we mentioned inflammation there before, and I suppose diet and inflammation, there's a lot you can do with diet regarding inflammation. So we have a little video coming up on diet and inflammation. And after that, I'm actually going to hand over to my colleague Amy, who's going to speak with Professor James Wolfson on some of the work and apps that he's been creating recently, and also Rebecca from the Dry Eye Foundation in the US. So we're going to pass over to Amy after that video, but then we'll be back in studio with Conan and Laura after that to address lots more questions.
When it comes to managing dry eye disease, incorporating anti-inflammatory foods into your diet, which are rich in omega-3 essential fats and antioxidants, may help alleviate symptoms. While diet alone cannot cure dry eye disease, these foods can potentially support tear film stability and overall eye health. Here are some foods that are recommended. The best source of omega-3 is oily fish, such as salmon, mackerel, trout, tuna and sardines, because fish creates the active components EPA and DHA shown to benefit eye health. Make sure to incorporate a wide range of strong-colored fruits and vegetables into your daily diet. Try to eat the rainbow to get the most variety of antioxidants that may neutralize the damaging free radicals that our modern lifestyle creates, which then drive that inflammation. Look at those dog berries, blueberries, strawberries, raspberries, or the citrus fruits like oranges, grapefruits and lemons. They are packed full of colored antioxidants and vitamin C to help with that fight. Leafy green vegetables like spinach, kale, Swiss chard, or a variety of fresh herbs are packed with antioxidants such as vitamin C and E, as well as lutein and zeaxanthin, which may protect the delicate tissues of your eyes. Try my anti-inflammatory Very Berry smoothie. It's a delicious example and an easy way to incorporate some of these foods into your diet to help manage your dry eye disease.
Fantastic. Thank you very much. You are all very welcome to the last session before our Q&A panel discussion in about 15 minutes. This session is all around self-advocacy and the lived day-to-day experiences that we have as patients. I am absolutely delighted to be joined by Rebecca Petries, the founder and executive director of the Dry Eye Foundation based in the USA, and Professor James Wolfson from Aston University. Thank you both so much for joining us today. You both come with such huge knowledge and experience in terms of eye care, ocular surface disease, and that patient first focus as well. So Rebecca, I'd like to turn to you first to share a bit about the foundation and what are patients experiencing? What support are they looking for from you? From our side, we're seeing more and more research published around holistic health management, focusing on both physical conditions and mental conditions as well. So if you could share a bit about the foundation, that'd be wonderful.
Absolutely. And first, just thank you so much. And thank you to Scope for putting together these amazing events. And I'm just really honored to be part of it. So Dry Eye Foundation is working on a lot of things. We get involved with some research, and right now we're in the middle of a big campaign on eye drop safety. But our core, I mean, our most important reason for existence really, and certainly my personal mission, is to offer as much support as possible to people who are at a stage in the dry eye disease journey where they become very anxious and overwhelmed, depressed, maybe sometimes almost hopeless. I think anxiety in particular is feeling almost universal in the dry eye world right now. So I want to talk a little bit about why we get to that point and what kind of support seems to be most helpful. I think people at a point in the dry eye disease journey, we are carrying this burden that just seems like it keeps growing. I think of it as the dry eye disease burden. It's basically 4 pieces. And the first part of that burden is where it all started, and that's the functional impact of our symptoms on our lives. Can I do what I need to do each day? Or can I do my job in reasonable comfort? Or is my concentration constantly being interrupted by eye irritation or pain? Can I drive the places I need to go? Or are my eyes so uncomfortable it's just hard to keep them open long enough? Can I sleep through the night and get a good rest? Or am I up 3 times a night putting in more ointment? Can I take a walk outdoors? Or am I so sensitive to light that I'm actually starting to feel housebound by dry? Can I socialize? Or am I just so depleted by this relentless thing that I just need to rest at the end of the day? Am I so uncomfortable in various types of environments that I just can't be the places I want to be? So we've got all these functional impacts where it starts. Second part of the burden is the medical care piece and just the realities and challenges of trying to navigate care. I think finding skilled doctors is top on a lot of people's list. It's a fairly universal problem. Getting a detailed, thorough diagnosis. People with dry eye also often end up feeling like they're always in the driver's seat, and we don't necessarily want that. Then there's this conundrum for us with kind of the totality of the experience that everybody calls it dry eye, and it just sounds like this little thing, right? But our experiences of medical care may feel much more like the experiences of somebody who's got a rare disease. It's that difficult to find our way to the information and the help that we need. Then the third part of the burden is costs, and this looks vastly different, maybe depending what country you're in and what's available and what your finances are like. But I think that access to timely care and effective treatments just on the basis of cost is a huge source of stress to an awful lot of us. And then the last part of the burden is the emotional piece. Anxiety and depression really are just like the sum of the first 3 pieces, right? I mean, of course you're anxious and depressed when all of this is going on. But then anxiety and depression can become really crippling. And what's heartbreaking is that these things, they're caused by the disease, right? But then they interfere with our ability to get things under control. It's much harder to communicate effectively with doctors. It's harder to advocate for ourselves. And it's hard to make good medical decisions when we're under this much stress. So we have this 4-part burden, right? So what does support look like? At the foundation, our support pieces are really three different things. We run a lot of groups. There's Facebook groups, I think a lot of people are familiar with, but we also have Zoom groups where we've got small groups of people sharing about their experiences, swapping tips, pooling our community wisdom and knowledge that we've gathered. I just love the Zoom groups. We have them on a variety of topics. We have a UK group as well. We also try to set people up with a dry eye buddy when we can, somebody to just be checking in for some kind of week-to-week support. And then this is where my heart really is, in our helpline service, which is a phone calls or Zoom calls by appointment, where we have one-on-one conversations just as long as needed to help people with whatever practical thing it is that they're struggling with. And I spend a lot of my time personally on that. So those are some ways to get support. But what is kind of the nature of support that we need in that situation? What's the value of getting connected, whether it's through the Dry Eye Foundation or some other resource? I think there's really three key things people find themselves in need of. And first of all, just the sheer comfort of being understood, right, by somebody who's been there. I mean, no two people have the same experience, but we all have important shared elements of our experiences. We speak the same language. And even if we have an exceptional, empathetic doctor, and many doctors have dry eye and can speak to that experience, but even so, they don't have the same experience as a dry eye patient who isn't an eye doctor. An eye doctor's experience of dry eye is going to be fundamentally different than mine is. So dry eye disease becomes this very isolating experience, and connection is essential. When we feel heard and understood by someone, at least, we can engage more effectively. Second part of support is orientation and information. People in this situation need a kind of a map, something to contextualize the experience, a way to reframe the problem, shifting the kaleidoscope to see a little different picture, and most of all, to know that where I am right now is not where I'll stay. And I think a super important part of the encouragement people need is to know it doesn't stay like this. We hear these scary words like chronic and progressive, and it's terrifying. It's like, my experience right now is going to be the way things are, only worse later. Oh my God. But the reality is it gets better. I mean, I can't predict what will happen with anyone's eyes, but I know that the full experience really gets better. You get to a place where things are better managed, where you're more comfortable, where you're more confident, where you're feeling in control, where you have tools and resources. That
I want to jump in on that part, Rebecca, just around the tools and resources. I know from the foundation, I personally am a big fan of things like the Dry Eye Happy Hour, and I'm quite intrigued by the helpline as well. And I just want to invite James to jump in here just for a quick second. We're a little bit tight on time, but we're going to come back to you in a minute, Rebecca. James, your focus on patients is extremely inspiring to me, and I know it's a personal passion point for yourself. We did give people a bit of a sneak preview or a teaser in an email that we sent out earlier this week around a very exciting project that you have been working on in Aston University. So I'm going to invite the events team to pull up a video alongside you on the screen if you would like to talk to us about the app that you're getting ready to launch in Aston University for patients.
Sure, thank you, Amy, and thank you so much for having me into this talk. So I deal with patients as well as being an academic and a researcher in this area. And a lot of those patients were really asking for something to help them when they're seeing particularly multiple clinicians, to be able to pass on that information without having to repeat it all, and also to be able to collect a bit of their own data. So while digital devices can cause problems, of course, in dry eye, they can also help us and be part of the solution. So this app that we've developed and will be launching hopefully later this month, early next month, allows us to provide that information to them. It's simple to use. It allows you to track your own symptoms. It allows you to have a look at your risk factors. So things like lack of sleep and hydration, these sorts of things. So again, you can identify the things that perhaps might be modifiable, or just accepting that these are a factor for me. As you can see on this slide, you can find dry eye specialists in your area with a particular technique that you want. You were talking about IPL, for example, before. But it also allows you to actually put in the drops or medications or even the in-office techniques that you're doing, so you can see when they happened. For drops, for example, you can set reminders, so it will allow you to remember to take it, and whether you want those to be strict reminders or only when you forget a certain number of times. But actually we can even attach a label to a bottle now, so you can tap it against your phone and your phone will register that actually you've taken that medication at that time. So hopefully it allows you to improve your compliance, engage with your eye care practitioner more, and on things like the treatments, it's got ones where it talks you through, for example, blink exercises. So again, if that's something that you've been told might help you, it will actually support you through that.
Absolutely incredible. And I have to say, everyone here in Scope, we're so delighted to join you as a sponsor for that app, because patients are our number one why. It's why we do everything that we do in Scope. One thing we say very regularly, and it's come across in this event, that we highly recommend that people go back to their healthcare professional if they have questions around a treatment or different options or recommendations that they have been given. For me, James and Rebecca, you are the experts in terms of supporting patients and empowering them to bridge that gap between diagnosis and disease management. To wrap up, can I ask you both to give 2 top tips to patients in terms of how they can better self-advocate for themselves to have that really great collaborative relationship with their HCP?
Rebecca, do you want to
James,
start?
I'll invite you in. Yes, please.
Sure. I would say 1, set a goal for an appointment. Go thoughtfully into the appointment. Bring a friend if you can, bring a family member or something. But setting a goal, narrowing it down. Don't go in with a laundry list of 25 different questions. Realize it can't all be done in one appointment, but think in terms of a specific thing you want to achieve in that appointment and communicate it clearly in advance, if possible, to your eye doctor. Number 2, in the appointment, again, most doctors can't answer every question at every appointment, but don't hesitate to ask for more resources. What are the websites that your doctor trusts and recommends? Do they have any leaflets? What are the additional information pieces they can give you, or sources they can give you to support everything you're going to come away from the appointment with?
Amazing. Thank you. And James, your 2 top tips for patients?
Yeah, so linked with what Rebecca says, certainly prepare for your appointment if you can, and if your practitioner can send you through, for example, a questionnaire beforehand, and you can actually have the medication that you're using on hand so they can get an accurate record. That really helps and saves time, so you can actually spend more time speaking with your consultant. And then the other thing is, do keep a good record of how things change over time. There's a seasonality, for example, often to dry eye, or certain features of that environment that are making your eyes worse. If we can understand those better, then we can prepare you for that and hopefully reduce your symptom level.
Absolutely incredible. I know there's a lot of questions that have come in, and we'll make sure that our team is populating the chat with the links and signposts to the great resources that both of you offer. From my side, thank you both so much for logging on today and for everything that you're doing. James, I believe there's a graduation on in the university today, so I really appreciate you jumping into the call.
In the background there.
Oh, fantastic. I was hoping you'd arrive with the gown on. We're going to take a break now before we move into the Q&A session. So there's going to be a bit of music playing and just a holding slide. So take a drink of water, stay hydrated, and take that time to blink before we move into the Q&A, and we'll be back in about a minute or 2 minutes.
Welcome back, everyone. I hope you had a nice blink and a nice drink of water and whatever you needed to do for that little comfort break. So we have now 30 minutes to get as many of your questions addressed as possible. So I have Mandy and Indy back in studio with me. Welcome back. And I have Conan and Laura back online, Dr. Perryman and Conan Tan back online. So you're very, very welcome back. I'm looking at a lot of questions and I'm not quite sure where to start, but we have ones on IPL, we've got ones on medications, we've got ones on drops. So I think I'm going to start with the IPL ones, and just a very, I suppose, the reality of it. There's someone here that does not like getting my bone gland squeezed after IPL, and it's sore, it hurts. So I see a lot of nods, a lot of yes, we understand that. So Laura, you were first to nod there. So I'm going to go to you. Is it sore? Is it uncomfortable? What do you do?
This is a great question, and I use that as helpful information. So I don't always express. Some studies use expression, some studies don't. But really, if you have to apply so much force after IPL that it becomes painful for the patient, that's an indication that the quality of the meibum hasn't improved enough, or that there's obstruction. And I don't want to be squeezing on a tube of toothpaste with the cap still on. That can be an indication that the patient actually needs another advanced procedure, such as a mask and probing. Suggests that there might be intraductal scarring going on that has to be addressed to allow the meibum to be expressed. So if there's a lot of pain involved, that actually tells me quite a bit about the patient's individual situation.
Thank you, Laura. And I think, James, you were second to nod there, so I'm going to come to you on that one if that's okay, because I know you may have to go back to the graduation, but just, is that something that you come across often?
Yeah, it's absolutely true. You know, there are some patients that find it more uncomfortable. We can't totally anesthetize the eyelids, for example. And it is a good indicator of whether there is still inflammation there, and perhaps we need some more treatment. Expression in its own right can be a treatment, so there are some patients who will tolerate it. But I always say to patients, you know, this is something that won't be 100% comfortable, and therefore, you know, let me know if it's something that we need to stop at this stage, and maybe we need to do more therapy before we move forward.
Okay, I think there are two great answers that you know, reassures that patient that sent us in that question. So thank you for that question, because I think from the amount of nods I saw there is probably a lot more than one person feeling it as being sore and hurting. Okay. And the next one, as I said, I'll stick with the IPL for now. So I'm just going to read out a little patient case here, and we can comment. I've done 6 IPL, no improvement. Every omega fatty acid, mask, drop, diet, vitamins. I'm not getting anywhere. Days are tolerable. The days that are tolerable, I can't remember what moist eyes feel like, but nights are torture. So they're going to see a specialist in September, so that's great that they're getting to a specialist. What do I ask for? This person is at a brick wall. And I wanted to read out this because there's so many people on this call that need the experts like you, the real experts in the world, to help them progress and find local treatments. And what should they ask for? So, you know, they've done the IPL. From reading this, they've done an awful lot. Anyone want to jump in there and just help that patient, or just tell them what to watch out for or ask when they're going to their specialist?
Shall I start?
Yeah, please continue.
I think importantly, a really good diagnosis with lots of imaging is very important to understand where the patient is starting from, and what are the potential effects of the IPL, and also helps us to indicate whether any medical treatment is needed at the same time to push that along. Does anyone else have more to add to that?
That's exactly my strategy. I regroup, like do the diagnostics, look back at the situation with fresh eyes. And what did I miss? Is there something else that needs to go along here? Is there an underlying condition that needs to be treated? Or do we just simply need to increase our interventions until we get that patient under better control, and then we can simplify their regimen? So I do regroup as well.
Okay. Yeah, and there's certainly other therapies. I mean, IPL, of course, is one. There's studies now that show that low light therapy that you were talking about before can actually be more effective than IPL even on its own. And quite a lot of us will use that in combination, but there are then the pharmaceutical treatments. So as Conan said earlier, a dose of steroids tapered off, because steroids can cause problems in their own right. But a lot of practitioners will now use that to get people over that hump, while cyclosporin takes its time to work if there's an inflammatory cause. But referring back to Conan and Laura, it's really important that we understand that sort of baseline, where you are, what's likely to be causing this, and then addressing that specific problem.
Okay, so I think for this patient, make sure that you're getting a wide, holistic view of everything that's going on, and make sure you ask those questions. So thank you for that. Actually,
Throw in a thought there?
Rebecca, please, yes.
So sorry. Just from helpline experience and elsewhere, I find it staggering how often recurrent corneal erosion sometimes get lost in the noise of overnight dry eye. So, I mean, I've known a lot of people that just never got diagnosed until their third cornea specialist or something. I always encourage patients to get very specific in how they describe what's happening overnight. Am I waking up at 2 a.m. with sharp pain and blurred vision? Your doctor needs to know exactly that. Don't let it just become part of the broader noise. And then some of the just old school thing, you know, when I'm going through a stretch with really bad nights, I've got all the goggles and all that jazz, and you know, many of them are very helpful, but taping my lids down, that's what really does it, with a really soft silicone tape. Again, sometimes simple things.
Thank you. Thanks, Rebecca. And I'm asking questions, so everyone jump in that has an answer I want to add here, because I think the more we have voices, the better. One of you mentioned there about steroids. So just a very quick question on steroids. Is it okay to use steroids frequently? So Laura, do you want to take this, and maybe Conan then as an IP as well? Laura, steroids
yes,
frequency.
I hope the background noise is not too severe. Is it bad?
It's okay.
Not too bad? Okay, good. Phew, there's construction going on outside. Anyway, the question is regarding steroids. Steroids have a role. I know it incites a lot of fear and concern and anxiety in our dry eye patients, but your eye doctor is watching you for side effects. They're watching your eye pressure. They're watching your optic nerves. And steroids do have a very important role. So trust your eye doctor to help guide you through monitoring potential side effects. But steroids do have a very helpful role. Not all steroids are created equal. I like to lean on lower concentration, lower prednal formulations, and particularly nanomicellar formulations. And that allows for greater penetration through the tear film and the epithelium to get to the scene of the crime and clean up some of that inflammation load.
So Laura, just on that, if someone has a concern, is it okay, or Rebecca, you might know this more from chatting with a wide breadth of patients, but can they ask, is this a low dose steroid, and get the answer yes? You know, how do they check if it's a low dose?
The concentration and the formulation, and how much preservative is present. All of those things are under consideration when I'm making a prescription, a specific prescription recommendation for a patient.
Okay. Rebecca, anything from your side from patients and steroids?
I think, you know, we just have to make sure we're asking lots of questions, especially about, you know, how frequent follow-up needs to be. We had some heartbreaking situations in the pandemic where people were staying on steroids too long and ended up in uncomfortable situations with side effects afterwards. So just being very clear about the follow-up and what's that period and what you need to be checked for.
Okay, thank you. Thanks, Rebecca. And just staying on the whole medication side of things, huge amount of questions relate to cyclosporin. When do you expect to see results? How long? What is the dosage recommendation, etc., frequency of use? So does anybody want to jump in there regarding cyclosporin? And maybe just as well, for people that are not familiar with cyclosporin, just could you give me a background when you start somebody on cyclosporin, and then once they're started, kind of the treatment, please?
Sorry, when you started, did you say?
Yeah, like why would they be started on it? And if they're started on it, then when should they expect to see improvements?
I think initially it was licensed more for patients with aqueous deficiency, but I think we are now prescribing more and more for inflammatory signs. I guess some practitioners will prescribe it from the get-go. I personally would keep that in my kind of armory until I know that steroids alone cannot control the inflammation. It generally takes a few months for the doses to kind of kick in and for us to see if it's effective for a patient. The one available in the UK is called Icurvis, and that's licensed for 1 a day, but increasingly I believe that the dosage is going higher. People are going higher into 2 times a day, maybe even 3 times a day, and it seems to be having a positive effect in controlling inflammation. But it's a stepwise treatment, I would say, and unfortunately we have to be patient with it to see if it helps.
Okay.
Interestingly, there's some information from the refractive surgery literature showing that you can see improvements in symptom scores, refractive accuracy, and refractive outcomes, as well as higher order aberrations in as little as 28 days with pre-treatment with cyclosporin formulations. And it turns out that cyclosporin is this really interesting molecule. It's found in nature, and it hates water. It's like Jack Sprat's wife, and it only likes fat. So you have to treat it with great care, and the way you formulate it will very much depend on how much gets into the cornea to help calm that inflammation. So formulations do matter.
Yeah, and that's the other thing to say, not all cyclosporins are the same. The early cyclosporins did take a while to work, and some patients never got a benefit from it. And that's why in the UK now they'll normally do a steroid first and then taper that while the cyclosporin's building up to try and get people over that. Well, I'm getting no effect from my cyclosporin, but there are new ones coming onto the market now, just coming into approval, that seem to work much faster. So hopefully more successfully, but I wouldn't think about a therapeutic option normally until we'd seen that we can't manage their dry eye with non-pharmaceutical options, because of course all pharmaceuticals carry risk, and we're always weighing up those risk patient benefits.
And I think there, James, in that one, oftentimes it's the inflammation that we need to get under control. And I suppose I'm seeing a few questions come in here related to maybe if arthritis is flaring up, the dry eye is flaring up. So I don't know if somebody wants to comment on, I suppose, maybe I'm assuming here, but the whole underlying inflammation generally, and then dry eye disease. So James, do you want to just take that one, because you finished, so you're still on my screen.
So yeah, I mean, certainly there are lots of systemic causes that have implications on the ocular surface and therefore cause dry eye. And there's no point in us trying to manage the eyes in isolation in those cases. It really needs to be a partnership with a rheumatologist, for example. So that discussion absolutely needs to happen. And quite often the patients I see, there'll be several other medical professionals involved, and it's important then that we liaise together to make sure that the treatment is focused on what patients are doing. Rosacea is another one that often needs to be managed and can then have a significant impact on dry eye. But this comes back to what I was saying earlier about patients being able to record and document how things progress during the period between appointments, because that can give us as clinicians clues to what the sort of primary things are that we should be looking for.
Okay, thank you, James. Anybody else, or will I move on to the next question? Okay, move on to the next question. Actually, Mandy, I'm going to come to you, because James, we talk about systemic diseases, but systemic medications for other diseases. I mean, is there any one there regarding triggering dry eye, or is there any, when you take a case history and looking at people's medications, are there any flags to you that you're watching out for even more carefully if you see they're on a certain medication?
Oh, absolutely. I think systemic medications, there are so many that have dry eye listed as a side effect. I think out of the top 100, 22% of them has dry eye as a side effect. So it's really important when I take a history that I know the names of medications. And so if you are going along for an assessment with your specialist, take your tablets, all your medications with you by name, so that we can actually join up any dots if we need to. But I think the main ones are the antis, so antidepressants, antihistamines, antihypertensives. These all can affect our tear production. We produce less tears, so naturally we're going to end up with a dry eye as a result of it. I do think that it's really important not to suddenly decide for yourself that, you know, it's your pills that are causing your dry eye. You need to go and talk to your prescribing physician. You need to discuss alternatives. It may well be that there aren't any alternatives, and, you know, the benefits of taking the medication actually outweigh the side effects, and as miserable as the dry eye is, we can then work to give you as much relief of those symptoms as we can. But I can't stress enough, you know, you must talk to people, don't stop them yourself. And I think this is true of some eye drops as well. So there are some medications that their formulation are designed to target something else that might irritate the surface of the eye. It might be the preservatives that are irritating the surface of the eye. But again, talk to the prescriber, see if there's an alternative if you suspect that this is a problem. But definitely worth investigating. It is a big problem. I don't know whether the other panelists feel that too.
I find that some patients who understand, once they understand that certain medications are a cause of some of their dry eye, they can manage it in a better way and can be a little bit more accepting of why they've got the issue. And so that's where, as you said, ocular lubricants really do come into play to help replace the tear film whilst they are on the medication.
Absolutely. And I think, maybe going forward, if prescribers are prescribing a medication that has got a known side effect of dry eye, maybe we should be given advice at the point of prescribing that we may need to use lubricants as well. That may be a long way off with the NHS, but in an ideal world, I think we should be having that conversation from the beginning.
Okay.
I think it's important also to for patients to be reminded that just because a medication may increase dry eye symptoms doesn't mean it will. I see a lot of people in our community that are frightened from taking what really are medically necessary drugs because they say this is going to make my dry eyes worse. And it's because we're so traumatized by some of the pain and the relentlessness of symptoms. We're afraid of any increase in symptoms, right? But the realities are, it's a percentage of people that get it. It's not everyone.
The placebo effect, is it? We sometimes, Laura, you're giving thumbs up there.
I'm cheering in the background, despite the noise outside. That was such a good point, and I so appreciate that. Particularly when you have a patient who's very impacted by anxiety and depression. It's a chicken and egg horse and cart. Sometimes that's a predisposing condition. Sometimes it happens because of their disease state, and it has to be treated with care and compassion, but sometimes medically. And so I love what you said so much, that it doesn't always mean that it will dry you, and just having an improved floor for that person on a biopsychosocial level can really help the doctor turn things around for that patient. Love that.
Thank you, Rebecca. And James, I know you need to get back to the graduations now. You need to put your robe back on. I don't think you're going to put the robe back on for us, but James. The hat will do. The hat will do. We really Thank you, James, and we look forward to seeing your app, and we really look forward to see how it will help patients going forward in the future. So best of luck with that.
Lovely, and thank you to Scope Again for their support.
Very welcome. Thanks, James. Okay, lots of great questions coming in. So, but kind of random a little bit, but just one thing that came up there was just somebody with glaucoma medications that preserve. So, Mandy, I think you described there that, sometimes preserved medications can actually, we just need to be mindful of the ocular surface as
Absolutely,
well.
Yeah.
Okay. We might just move on to Sjogren's. I think we have a lot of Sjogren's patients on the call. There's a lot of questions, and I can feel nearly the despair from some of this. I suppose, Indy, one question that came in earlier on was like regarding the best dry eye drops for Sjogren's. Have you come across that question before? Or?
Yes, a few times. It does very much depend on sort of the specific patient. A lot of the times with Sjogren's, they've got sort of poor quality tears, or also just not enough volume of tears. So it very much depends on the patient. But they might want to sort of look for a more viscous drop, like we were talking about earlier, just to sort of give them that longer lasting relief, just so it stays longer in their eye as well. Just to do that. Mandy, would you agree? Would you add anything different?
I think so. I mean, it's still... we do sympathise with you. It is a really difficult condition to live with. There's so many factors to it, but it is all about just keeping that ocular surface as moist as we possibly can.
Okay, we've got some nice music there to complement that, Mandy. So thank you very much. Just one thing. I've got another. I'm going to read out something that came in. Who needs to monitor dry eyes for people with Sjogren's? Should monitoring begin when dry eyes not causing a large problem, rather than just told have dry eyes and occasional burning in the eye? So who's responsible for this dry eye bit as part of Sjogren's? Oh, it's a tough one.
It's a great-
Amanda, do you want to
it's a great
start?
question. I'll start it, and
Okay.
I welcome anybody else. Personally, I think if you're newly diagnosed with Sjogren's, you're probably going to have some ocular effects or some symptoms anyway. But if you haven't, I think it's great that you should start looking after your eyes, look after your ocular surface, keep your lids nice and clean, instill good hygiene with your eyelids, so that maybe you're preempting any problem before it comes. So I think good education, and know that you've got to look after that ocular surface. Maybe make sure you see an ophthalmologist or an optometrist and have a baseline assessment done to see if there are any early signs that could be addressed.
Okay. Laura, Conan, I'm sure you see a lot of patients.
Yeah, I agree. I mean, it's interesting, isn't it, with early Sjogren's, that they might not have the aqueous deficiency component yet, but you're right. If they are addressing that to begin with, preempting it, then there may not be that trigger that causes that inflammatory cycle in dry eye, and so they may reduce that kind of severity and even onset of the dryness. I don't know if you agree with that, Dr. Perriman.
Sorry, there's so much background noise. I hope it's not disruptive. Yeah, we take a very systemic approach to the Sjogren's patient. There's inflammation coming from within affecting the lacrimal gland. And so you can protect it with your immunomodulators. There's been evidence showing topical cyclosporin can help protect the lacrimal gland. But then we're also quick to recommend these nutrition recommendations. The anti-inflammatory protocol nutrition plan, your omega fatty acids with a 3 and 6 balance are helpful in reducing inflammation, specifically in the Sjogren's patient. And there's also multiple therapeutic systemic modalities that can really help the Sjogren's keratitis patient. I just sent a link in the chat earlier about one in particular for recalcitrant keratitis. And that's a strategy we will do early and often for our Sjogren's keratitis patients. One thing I do want to point out, one of the happiest groups for IPL for treating dry and MGD is the Sjogren's patient. I have never ever seen a Sjogren's patient that didn't have MGD. And that's why we don't split the disease state in aqueous and evaporative. It's a double vicious circle cycle, aqueous and evaporative at the same time, centered on inflammation. So inflammation is my #1 bullseye target with every arrow I pull out of my quiver, a bag of tricks, to get it under control.
Thank you, Laura. Thank you. Rebecca, have you many patients that are Sjogren's patients as part of your group and foundation?
Yeah, we have quite a lot. And there are a lot of people, it would be nice if everyone just knew, right? But there's a lot of people that go for a long time not quite sure about a Sjogren's diagnosis. Maybe they've got negative blood work for a few years, and then eventually someone who has a ton of experience, some eye doctor that has a ton of experience with Sjogren's, takes one look and is like, you have Sjogren's, right? So it's a process, I think, for people to come to grips with that as part of the picture.
Okay, thank you.
I heartily agree. And it's important to catch Sjogren's earlier in the disease state to Conan's point earlier that aggressive early treatment may help prevent progression. So if you're suspicious of Sjogren's, family history, dry mouth, dry skin, cognitive fog, neurologic problems, peripheral neuropathy, dry eyes, all, excess cavities that you never used to have, sleeplessness, all of those things can be associated with Sjogren's syndrome. There are early blood tests that are not typically done by the average general practitioner that show up well before the later stage Rowe and Lauer SSA and SSB biomarkers. So maintain that high index of suspicion, and you can get some special blood testing just to look for sure.
Okay. I think that's
we
really
send a lot of people to
yeah.
Sjogren's Foundation because they have tons of information there as well.
Great, Rebecca, we might actually get the link to that and put it into the chat function so everybody can see. So it'd be great to get, so everybody can get that link. Thank you. Just to change tack a little bit, but systemic as well, but HRT, hormones, etc., and the role for dry eye, etc. So There's no specific question here. It's just like question HRT. So I don't know if that's the vagueness of it or regarding the research, etc. So Conan, I might come to you first. I just see you nodding there. So do you want to just comment on that and HRT?
I was nodding to the vagueness
Right.
of it, because I think I can't say I'm the most experienced with the HRT and medications according to that, but patients will have different effects with HRT. This is anecdotal. I have patients who have taken it and has a negative effect on them, and some who have taken it and have massively improved them. That's all I'd say to that, and that's why I was nodding. So not nodding that I knew the answer.
I think that's an answer in itself, though, isn't it? And I don't, Laura, do you want to comment on that?
I missed the question because there's hammering. What was it again?
Oh, HRT, Laura, the impact of HRT and its linked to dry eye.
Hormone replacement therapy.
Yeah.
It's great for protecting your heart, your brain, your bones. And it's a mixed bag when it comes to dry eye exacerbation, ocular surface disease. So you have to weigh all of those risks and benefits with your doctor.
Okay, so have that individual chat. That's one for an individual chat. Okay. Actually, Indy, we have a question here. Just in relation to lubricants, I mean, should you change lubricants after a certain amount of time because they lose efficacy? Or, is it something that you stick with?
Not necessarily. I think if you've chosen a drop which is preservative free, like we discussed earlier, and it has great ingredients, because I think, as you were saying earlier, with steroids, they're not all made equally. Same with eye drops, they're not all made equally. As long as you've got a good constituents of ingredients in there, such as sort of sodium hyaluronate and preservative free, and it's still working for you, I don't really see any reason as to they don't lose efficacy. No, I wouldn't think, if you're not having any issues, there's no need to change them.
Okay. Just one other, again, and just these are random questions, but just to make sure that we cover all the different kinds of patients that are on the call. I have wet macular degeneration and also dry eyes. Are the two conditions related, or can one have an effect or exacerbate the other? Mandy, you're smiling. Go for it.
I think it's more the treatment for wet AMD that can exacerbate the symptoms of dry eye. It's the intravitreal injections and the whole process of having that injection that can sort of aggravate the ocular surface, can compromise it, whether it's the antibacterial that you have painted around your eye, the whole process of and surgery in general, the lighting, and we often recommend, I know in our area, that if you're having a course of these intravitreal injections, that you would then use a lubricant afterwards, just to sort of harmonise the ocular surface, rehydrate the ocular surface. I would always recommend, though, and I don't know if the others agree, that you would start a new bottle of lubricants, regardless of whether they're preservative. I mean, obviously we'd like them preservatives free, but whatever type they are, fresh bottle after each injection, just to be cautious of any contamination or anything.
Okay. Conan or Laura, do you have anything else to add that you may see in those patients, or do you see many of those patients?
Yeah, I would just like to add that out of necessity, we have to sterilize the ocular surface before the injection, because we're all doing our very best to avoid the dreaded complication of infection inside the eye. So it's a step that cannot be skipped. However, in the act of doing that preparation before the injection, some of those agents can be very drying and can be very harsh on the goblet cells. Now, I've had multiple retina colleagues tell me, when I started treating the dry eye, because I was getting a lot of calls after these injections with topical cyclosporin, after a couple of months of use, there was less complaints. And cyclosporin is uniquely beneficial in supporting the goblet cells. Remember that act of that prep is a desiccating stress and can incite inflammation that you can mitigate with cyclosporin, in addition to all of the wonderful moisturizing hyaluronic acid containing preservative free fresh bottle, love that tip, eye drops that you use afterward.
Okay, so as part of the overall management, I think it's important not to forget about it. I hate to say it, but we've come to the end of this patient event. I want to sincerely thank Dr. Perryman. Thank you so much for joining us, Mr. Conan Tan, Rebecca Petries, Mandy Davidson, and India Pal. So thank you so much. I think you've brought so much practical insights into today's questions. I think, again, we could have one next week and we'd still be able to fill it with questions. But we've tried to answer as many as we can. I know the team, I can hear the keyboards are on fire behind me trying to get back to you with all the questions. So thank you all for joining us today. We appreciate your time and we hope that you found it valuable. We are always looking for new ways to bring you information. So, you know, we will, at the end of this call, have a little survey for you to complete. Please tell us what you liked. Please tell us what you didn't like, maybe, and tell us what you might like to see for the future. And at Scope, I suppose we'd love to be there for you, to give you the resources, and we are open to any way that we can try and help make your day-to-day life a little bit better. So on that note, I hope you join us again next year. And again, thank you very much for your time.